our next speaker, Dr. Saravanan VR, Macular hole and Schisis.
Thanks, Subjit. I'll be talking about a few of the miscellaneous topics which are not covered in the main list. So, myopic traction maculopathy, initially when we were before the pre-OCT era, we were not able to identify the tissues getting distorted in the posterior pole. So, but after the OCT came, you can see that in the first picture, you can see in the right, you can just see the stiffness of the sciatic posterior vitreous. You can see the early traction maculopathy where the inner layers are getting pulled up. And a little bit more severe case, in another case, you can see the early sciatic spaces here. Here you can see the early sciatic spaces, and this is the stiff posterior hyaloid, sciatic posterior hyaloid, which is the main pathological factor which causes all these changes. Here you can see an inner lamellar hole, and here you can see a full thickness macular hole with a posterior pole detachment. And whenever you have a posterior pole detachment in a staphylomatous in an eye, it is usually because of the myopic, because it's very unusual for a macular hole to cause retinal detachment in a normal patient. It only happens in a high myopic patients. And you can see at the base of the hole, you can see the presence of myopic macular schisis. So this is the most severe stage of myopic traction maculopathy. So initially, even though multiple names were given to this entity, right now myopic traction maculopathy is the most preferred and accepted terminology which is currently being used everywhere. And here you can see one more case where there's a secondary CNVM along with the presence of very severe myopic macular schisis. And you can even see a small dome-shaped macula, which also is common in patients with high myopia. The central macula sorts of juts in, causing a dome-shaped macula. So this can also produce complications like serous maculopathy, like CSR, like CRS maculopathy. Again, showing a severe schisis inferior to the macula here, fovea here. So the pathogenesis, why it happens is because of the stiffening of the ILM, the non-redundance of the retina, atrophy of the RP and choroid causing loss of that negative traction suction force, and incomplete PPD and the sciatic vitreous. So all these stiff vessels also, all these have been suggested as a cause of this myopic traction maculopathy. So when ILM was sent for histopathological evaluation, they showed that the collagen fiber and cell debris were identified in inner surface ILM in most of the cases of MTM, which is than normal patients. So first, what they tried was routine vitrectomy with or without gas, and so this was one of the first with ILM peel. This was first described for the treatment for this entity. And you can see from the published article the response to vitrectomy with ILM peel. You can see the resolution of the schisis as well as the closure of the macular hole. One more case, sometimes if there's a large subfoveal detachment in the absence of any break, the fluid can take a long time to resolve because of the absence of healthy RP. The pumping mechanism is not that very great, and it takes a long time for the fluid to come down. So just showing a small case of short case of video of myopic macular hole here. You can see the loss of contrast because of the atrophy of the RP in the posterior pole. So identifying the ILM is not very easy. So I'm using, because of the fluid also was there was a focal RD in the macular posterior pole. So I put PFCL also, stained it with now trypan blue. And you can see that when I'm trying to remove the ILM, what I removed first was the sciatic vitreous. You can see the rubbery consistency of the first tissue. This is actually the sciatic vitreous, which is not identified. Nowadays, people use triamcinolone to identify this membrane. Now, second time what I am peeling is the ILM. So, using PFCL helps to prevent the dye migrating into the subfoveal space in the case of posterior pole detachment. So, this is a short video of how to do ILM peeling. And using contact lenses also gives a much better depth perception compared to routine and non-contact viewing systems. So then Richard Spade, he described where he identified using triamcinolone, he identified the posterior hyaloid and removed the posterior hyaloid and the sciatic vitreous, but he did not do ILM peeling. So he showed that even without ILM peeling, with proper removal of the vitreous, you can reattach these cases. So next choice is to push, instead of push the retina from inside, push the sclera from outside. A lot of myopic macular buckles have been tried. The most popular is Andoplob and the JBL buckle. So in India, a lot of the T buckle, this is what we in India, because it's quite cheap, around 3,000, 4,000 rupees, but it's a little bit more gruesome. The orbital inflammation post-operatively is very severe. This is just a small video of the JBL buckle being placed. So just to expose the temporal area, the superior, inferior, and the lateral rectus, and then do the ILM peel. So once you finish the ILM peel, then this is the endosperm actually. So they put a light pipe to assist in correct positioning. This is just pushed underneath the temporal rectus, lateral rectus, and the light shows the positioning of the buckle is in correct situation, and then you can just suture it. And this is the post-op resolution of the. I can see the closure of the hole and the resolution of macular schisis following the placement of an endopalm. And you'll be a change in refraction because the sclera is pushed forward, so you may have to change your glasses also. So this is how various techniques for treating myopic traction maculopathy. Then we'll come to the second topic, that's the optic disc pit maculopathy. This is a little bit of a rare entity, not seen commonly, and this is one of the congenital anomalies of the disc, which comes under the optic disc coloboma, morning glory syndrome, and all those things. It comes under the same scheme. So here you can see that the fluid accumulation happens in both the intraretinal and the subretinal space, and along with the changes in the RPA also. So where this fluid comes from, how it enters the subretinal space or the intraretinal space is again a question. But the most accepted theory is that because of the defect in the optic disc and cribrosa, the vitreous schitic fluid enters through the pit into the intraretinal and subretinal spaces. So you can see, unlike CSR, you see intraretinal schisis or fluid accumulation in the intraretinal apart from the subretinal space also. So various techniques tried for this entity is, first they tried barrage laser to the pit, just temporal to the pit area, either two overlapping rows to prevent the fluid migration into the subfoveal space. This only takes scar if the peripapillary area is still attached. The peripapillary area is detached, then this is not going to get have any effect. So next was people have tried plain gas injection without vitrectomy, like a pneumatic displacement, which you do for submacular blood. Then people have tried vitrectomy with ILM peel or without ILM peel, and also gas injection. So all these techniques were initially tried with a limited success. Barrage, plain gas, vitrectomy with gas, vitrectomy with ILM with gas. Then Spade et al., he described inner retinal fenestrations. He proposed that by creating partial thickness injury to the peripapillary area by a sharp needle, the fluid which enters through the optic pit exits back into the vitreous cavity. So his theory was that you can just redirect the fluid back into the vitreous cavity by creating inner retinal fenestrations. He showed some cases which succeeding with this technique, but we tried and we could not have the same success. So right now, what is most popular is plugging of the pit by various tissues. Like some people have used fibrin sealant, some people autologous blood, some people have used scleral flap, and also ILM. This is one case of ILM peel for a macular pit. You can see that here they did a fovea involving ILM peel. So the risk of fovea involving ILM peel is that when you do that, if its foveal area is very thin, it can produce a iatrogenic macular hole formation, which happens. So you just peel all the ILM, and then under air you just plug it into the optic disc pit. You can see that even though the SRF resolved, it produces a secondary macular hole. So nowadays what we do is more of a fovea sparing ILM peel. So there's a kid with a hole. So you can see that the ILM peel is started nasal to the fovea, so that the fovea itself is spared. And then you peel the flaps, and then under air you just push it into the optic pit. So this is the ILM peeling technique. Now, which is much more successful than the ILM peel, is the scleral plug technique. So you take autograft from the same patient, trim it according to the size, the whole size, whatever optic disc pit size you see, and then just slightly push it into do a vitrectomy. ILM peeling may not be needed in these cases. I don't usually do ILM peeling in these cases where I'm going for a scleral graft, and then push the graft into the pit area. So this goes and plugs, and this is the OCT showing the pre and post resolution of the graft. You can see the graft sitting on the optic disc pit. Last is the unusual or inordinate migration of subretinal PFCL in patients who have undergone RD surgery. Here, because of the bubbling when you're exchanging instruments, because of the jet force of the infusion fluid, the PFCL bubbles breaks into small bubbles which can migrate in under the breaks and go into the subretinal space. So what we can do here is there are 2-3 techniques which we can do. One is if it's a very small bubble and you don't want to injure the macula, create a hydrogenic macular hole. So what you can do is you can create a small bleb of RD at the posterior pole by using either the 40 gauge needle or as Dr. Avijay taught me, I use the 30 gauge needle also. Then you can push this subfoveal bleb of PFCL into the peripheral area, and then as you aspirate the subretinal fluid, the PFCL bubble also gets removed. This is one technique when the bubble is very small. So you can see that this is what Dr. Abhijit taught me. You can see that I'm breaking the 30 gauge needle, which routinely used for intravitreal injections, and hooking it onto a routine intramuscular 24 gauge needle and creating our own contraption. This is a little bit cumbersome, but if you have the 40 gauge needle, which is much more easier to use, but in case you don't have access to that, and at the OT, if you don't have this, you can use it as a backup tool. So this is then connected to either a silicone injector filled with BSS, or you can use ask your nurse to inject through a 1cc syringe. So this is a second post-op. It is best to remove the PFCL as early as possible because it can cause permanent phototoxic effect. So the oil is still inside in this patient. I'm just bending and making this parallel to the RP at the level of the macula. The needle should be bent according to the curvature of the globe. And then once you inject, it will form a small bleb of RD. BS is injected under the retina. And then you aspirate this either using a 25 gauge suction cannula or a 27 gauge suction cannula, whichever you have access to. Before that, we just mobilize the PFCL so it's loose and easily aspiratable. So once you do that, then once you aspirate the submacular fluid, the PFCL also gets removed along with it. So this break need not be lasered, but because it was a one-night patient, I just wanted to make sure it doesn't go for an RD. Second technique is when you have a large bubble, you can make a nick at the edge of the base of the bubble and directly aspirate using either the 40 gauge needle or a 27 gauge soft tip, which I'm using in this case. So it's a pediatric patient who's got a large bubble there. So first is using creating a small nick with the 27 gauge needle there. And then using directly you can do this directly with your 40 gauge needle also. Then I'm using a 27 gauge suction cannula to aspirate this subfoveal PFCL. The last technique is you need not remove it. You create a inferior bleb of RD by injecting submacular BSS, and then push the PFCL bubble into the lower part of the macula and ask the patient to maintain sitting position post-operatively so that the bubble migrates out of the fovea into the inferior macula. So this also is one technique which has been tried. Thank you. I'll stop here.